When I went into emergency last week, I had to tell the nurse that I didn't have a blood pressure or a pulse. And she says, "What do you mean?" I says, "Well, I have the LVAD." And she said, "What's an LVAD?" So I had to tell her LVAD stands for left ventricular, I never pronounced that correctly, device. I said, what it is, it says when the blood comes into your body, it goes in the left side, and then it's pumped out over to the right side. There is a little machine right underneath the heart, right underneath here. The wire goes into the heart, and then it has like a centrifugal force that it pulls the blood out and then pushes it up the other side on your heart. She says, "Do you mind if I listen to your heart or take your pulse?" And I says, "Go ahead." And she listened and listened, and then she felt, and she says, "You don't have a pulse or a heartbeat." And that's what she says. She said, "Well, I know you're alive because you're talking to me." I'm Donna Jackson. I just turned 68. I have 2, 4, 5, 6, 7, 8 and a half great-grandchildren. I was never sick as far as sick, like I've never had chicken pox or measles or mumps. And I never smoked, I never drank. I just took care of my kids. I never once thought about my heart giving me problems. When I started having troubles, not being able to breathe and stuff, I went to the doctor. The doctor on call said, "Let's do another EKG." He says, "I don't like the way your EKG is looking." He did some tests and he said, "You're going to have a transplant." I came into Dr. Banerjee's about 2 weeks after I was told or something like that. It was real soon after I was told. And everything just hit me all at once. He was saying, "Well, your heart transplant or the LVAD or a defibrillator and this and that." And I was to the point where I just don't do nothing. Just let me go, I have a little great-granddaughter that is 7 years old, and she watches everything that's going on. And she had already lost her 2 great-grandfathers and her other grandma. And she was talking to me one day about that. I don't remember how it came up or what was said, but she told me, she says, "Well, I don't want you to go like Grandma and Aunt Rose did." She says, "I want you to stay around for a while." So I said, "Let's try the LVAD." That's how I made my decision. It was scary at first, but now that it's done, and I've gotten used to it, I can do more things. I got where I couldn't even walk from my car to the front door without having to stop and sit down and, take deep breaths, trying to get my breathing back. Now I walk all over Walmart, or I can, and I don't get that way anymore. But I do what I want to do. Well, I do most of what I want to do. I'm working on some of the other things.
Dementia is a very broad term, and what dementia means is that an individual has loss of cognition in 2 or more areas of cognition in their brain. So memory and language skills, or memory plus judgment. And if the loss of those cognitive abilities is severe enough to affect day-to-day function, we call that a dementia. Now, it turns out that Alzheimer's disease is by far the most common cause of dementia, but there are many other forms of dementia. Dementia and Alzheimer loss, unfortunately, are quite common, and it is age-related. So by age 65, about 5% of people will have a dementia. By age 75, it's up to about 10% of all people will have a dementia. And by age 85, 40 or 50% of all people will have some form of dementia. The risk factors for a dementia include genetics. On the average, each of us has roughly a 5% lifetime risk of coming down with Alzheimer's disease. If you have one parent with Alzheimer's disease, your risk goes up 3-fold. Epidemiologic studies show that the more education that a person has, the less likely are to have a dementia. A third risk factor is head trauma. People that have had head trauma, particularly severe enough to be associated with concussion, are at higher risk for dementia. The primary or early symptoms of a dementia, including Alzheimer's disease, most often consist of some form of memory loss. Particularly with recent events. So the person will ask the same questions over and over again. They'll forget about something that had happened just an hour ago or yesterday. The remote events from early in their life are often intact initially. It's the recent events that they forget. Other examples include the loss of what we call executive function, the ability to plan and execute. So for example, if somebody was previously able to prepare a meal that had 3 or 4 parts and they're multitasking, their ability to prepare that meal will become impaired. A third early symptom could be personality change. They become withdrawn, and it's just not them. Another problem would just be lack of verbal ability or verbal output. They're no longer able to express themselves. Another problem is what we call visual spatial skills, often manifests with driving problems. They just can't visually put their environment together. Or spatial skills, they get lost in familiar places. People often want to know, are there any signs early in life that they'll come down with a dementia or Alzheimer's disease? It's one of the biggest questions in our field. On a research level, there are certain approaches to brain imaging that might predict that someone is more likely to come down with Alzheimer's. But right now, for somebody in their 20s or 30s or 40s, there's no reliable way to predict who will actually get dementia, although there are ways to know if someone's at increased risk. There are a considerable number of studies showing that exercise, physical exercise, makes a big difference. People that are physically active have about a 40 or 50% reduced likelihood of coming down with Alzheimer's and some of the related dementias. That's a huge effect. The second strategy is healthy diet. There are a number of studies out there now showing that the so-called Mediterranean diet can reduce risk by about 30 to 40%. And then a third strategy is remaining cognitively engaged, cognitively active. You'll hear the example of crosswords puzzles, but it doesn't have to be that. It's just keeping your mind engaged with something interesting in your environment. So in terms of specific treatment options, I would put those in several categories. One goes back to just the overall lifestyle, getting enough exercise, physical activity, remaining engaged cognitively with one's environment, and diet. There are currently 4 FDA-approved medications that a neurologist or other physician will work with. They can make the cognition work a little bit better and delay things by 6 or 12 months. The third area to think about if somebody does have a diagnosis of Alzheimer's is entering a clinical trial to test an experimental treatment. One exciting area is the ability to detect this disease as early as possible. One area involves brain imaging, and we're fortunate here in Stanford we have some of the leading brain imaging people in the world. A second exciting research area is looking at patterns in the blood that can detect early or processes that might lead to dementia. And finally, the sort of new generation of treatments for this disorder attempts to go beyond just symptomatic treatment, but really attacking some of the underlying mechanisms that are causing the brain degeneration. And there are a number of teams here at Stanford that are making great progress in that area. None of these are ready to be clinically available to patients yet, but that's our goal.
When I was 24 years old, I was diagnosed with a life-threatening DVT, or deep vein thrombosis. They rushed me into emergency surgery and put in, at the time, was cutting-edge technology, the Greensfield filter. It was a very metallic-like device, shaped almost like a badminton birdie, only the prongs of the birdie were metal.
IVC filters are typically placed in the vena cava, which is the largest vein in the abdomen. We place these filters in selected patients who have developed blood clots in the deep veins of their legs. And the filter is designed to prevent these clots from migrating into the heart and lungs, where they could actually be life-threatening. There are 2 types of filters: the original permanent filters and retrievable devices that are now on the market. And both of these types can actually end up becoming permanent implants. We now realize that the risk of leaving a filter in place increases over time. And these risks can be fracture of the filter, with migration of components into the heart and lungs. Over time, the filter can actually slowly erode and impale adjacent organs, causing pain and injury.
About 10 years ago, I started getting abdominal pain. I was newly married at the time, and frankly, we believed that it was food-related. It started as a dull pain, but then over time, the pain got worse to the point where I couldn't really sleep through the night, and there were times that it really felt there was an alien in my stomach or a fork protruding into my stomach. I really had never considered that when I started getting pain that the filter would be the cause of the pain.
Susan developed a very, very serious complication from her permanent filter. She had had a device implanted over 18 years ago, and over time the device slowly began to erode through her vena cava.
The filter expanded to the point where 3 of the prongs were perforating my small intestine. And the filter was continuing to expand, which really made this a life or death surgery for me.
Susan came to us at the perfect time because prior to 2010, patients with these severe filter problems had very few options for treatment. And the referring physician happened to hear of some new experimental treatments which we had developed here in our interventional radiology department at Stanford. When Susan came to us, we approached it with a minimally invasive incision using only a 4mm skin nick at her neck site. And then we inserted a special catheter and guided that down towards her filter under image guidance. Once we reached Susan's filter, we're then able to insert our special endovascular excimer laser, and then we slowly started performing tissue ablation until we successfully freed her device. And using this technique, we're now able to remove a variety of permanently implanted devices that were previously considered irretrievable.
If I hadn't felt the pain, I never would have known that the filter was causing me trouble, and ultimately the final diagnosis would have been that the last 2 prongs would have punctured my small intestine or my aorta, and I would have died instantly.
Only now we're starting to see patients develop these problems after years of implantation. And so anyone who has a history of a filter implanted should make that known to their physician who's examining them and who's ordering tests, because there is a chance that the filter could be the culprit for many symptoms, just like it was for Susan.
Prostate cancer is a cancer of one of the male reproductive glands, the prostate gland. That gland is essential for male reproduction. It is in many ways likened to breast cancer. It's just about as common. It is related to hormones, in this case testosterone or androgen. It also is a very common cause of cancer death in men. Prostate cancer is the most common cancer in men. About 200,000 men per year get prostate cancer. If you look at it lifelong, a man has about a 1 in 6 chance of getting prostate cancer. The risk factors for prostate cancer include age. Secondly, family history of prostate cancer. Thirdly, African American race is associated with about a 2 times higher risk of getting prostate cancer and about a 2.5-fold higher risk of dying of prostate cancer. Prostate cancer is fairly straightforward to detect. We have been fortunate to have a blood test called prostate-specific antigen, or PSA. Since it has started, the death rate from prostate cancer has dropped approximately 25% or more. A man with an elevated PSA then undergoes a biopsy. The man has about a 20% chance of having cancer on a biopsy if he has an elevated PSA. For years we recommended men start screening at age 50. It appears that a better approach would be to start screening, get your initial PSA at age 40. If that PSA looks good, a man can wait and get another PSA at age 45, and if it continues to look good, get another one at age 50, and then maybe every other year or every year thereafter. Men who come to my clinic with localized prostate cancer, which is about 95% of men diagnosed nowadays, have no symptoms at all. They're shocked that they have prostate cancer. And it was found almost strictly because they had an elevated PSA. The things that have been associated with the risk of getting prostate cancer are high-fat diets, particularly animal fats. Some fats look like they might be beneficial, like polyunsaturated fats, fats from vegetables, fats from omega-3 fatty acids from fish. Some of the things associated with a lower risk of getting prostate cancer include eating a lot of green vegetables. By and large, what I tell patients nowadays is anything that is good for your heart is probably good for your prostate. The options for treating localized prostate cancer are active surveillance, watching the prostate cancer for signs that it'll spread. Prostate cancer is a very slow-growing cancer. For men with very small amounts of low-grade prostate cancer who might be older and have other health conditions, sometimes watching the prostate cancer is the most appropriate thing to do because they are never going to die of their disease. Surgery is probably the most common treatment for localized prostate cancer, particularly in men who are under the age of 70. The third mode of treating localized prostate cancer is radiation therapy. There are a lot of very exciting fields of research in prostate cancer right now. A number of investigators at Stanford are looking at the genetic profiles of prostate cancer to try and understand what makes prostate cancer cells tick. A second area of research is immunotherapy, revving up an individual's immune system to attack prostate cancer. I think this is the tip of the iceberg. I think immune therapy is going to be integrated into other forms of treatment, including chemotherapy of prostate cancer, to help improve and prolong men's life with advanced prostate cancer. New drugs are coming online for prostate cancer. These new drugs are in clinical trial here at Stanford and likely will enter our armamentarium in the next 5 years. This is a very exciting area of research and development.
The way we do healthcare becomes more and more complex every year because of the benefits of technology. And that means that we're constantly doing handoffs for patients. So the Health Library developed a mission statement that we would provide scientifically based health information to help patients and their families make informed decisions about their health care.
The library started when some people in the community approached Stanford Hospital and asked if we couldn't have a consumer health library to answer questions about their health and healthcare. It was at a time when patients didn't have a lot of recourse in terms of finding information out when they got a diagnosis. Mostly they depended on their doctors and their nurses to give them whatever information they had. Everyone was interested in doing it if Stanford would take the lead, and space was found in the Stanford Shopping Center.
We opened the doors and immediately we were inundated with people who weren't shoppers at the shopping center or just passing by and asking questions about medications for their children or the common cold. They were families coming over from the hospital who had friends or family members who were having serious challenges. They were fearful and they wanted information.
Very quickly, it became clear that the audience that we served was eager for consumer level information to begin with, and then very rapidly wanted much more in-depth, going all the way up to clinical information.
When a patient or family members walks through the doors here at the Cancer Center Health Library, what they can expect from us is the best research available on their treatment and their topic. They've been given a diagnosis by their physician. Sometimes they don't even know what body system is involved, and so they come in and say, I've been given this diagnosis. And healthcare is changing daily, so even just finding information on treatment is a very complex issue.
The people who come here are people who recognize that they may have a computer and they may be looking things up on Google, but they're not getting the information that they want. Then we have people who do not have computers. There's a certain generational cutoff. And then there are people who are really library lovers.
The internet has impacted healthcare information dramatically. I think the biggest impact is people expect when they go to the internet to find what they're looking for.
It's a really big, scary world out there on the internet. There's a lot of stuff and it's really hard to sift through. So it's nice to be able to help people sort of weed through the amount of information that's out there, but also make sure that they have access to all this really fabulous stuff.
We realize that everybody searches for health information and they're doing Google searches, but so much of the information online is not authoritative information. And so we can provide them with information that is current, authoritative, scientifically based, and then they can take that information back to their healthcare providers.
We now have many databases that we subscribe to. The material that we print out at any moment or that we email to patrons comes from the best scientific journals. We also are very fortunate that we are able to take advantage of Lane Medical Library's electronic holdings. We also have a very large electronic book collection, but what we really have that's of value is we have trained people, medical librarians at the top of that chart, and then our volunteers who get rigorous training to work with patrons to help them answer their questions. And having someone help you sort through it and give you the material that actually answers your question is really the irreplaceable piece that you can't get through the internet.
To imagine that we built something 21 years ago that is now still the resource for consumer health information, not just in our country but in the world, is incredible to me. The Health Library continues to be the basis of service and the navigation movement in particularly academic healthcare and the understanding what a patient needs at a time of challenge.
The brain in your gut is also known as the enteric nervous system. It's a collection of nerve cells, or neurons as we call them, that are actually within the wall of your entire gut, starting from the esophagus all the way down to the rectum. This brain or nervous system is quite independent of the other brain, the one inside our head. In other words, it can function on its own in what we call an autonomous fashion, and is very important for regulating the function of the gut, those functions being absorption, digestion, and moving material from one end of the gut to the other. The gut is a sort of a colloquial term that we use for the gastrointestinal system. The gut really is the engine that transforms energy in the environment to energy that's in a form that we can use. And without that function, life would not exist. What's also not commonly known is that it has more nerve cells than your entire spinal cord. And what's also not commonly known is that 90% or more of the body's serotonin actually lies in the gut, not in your head. And about half of the body's dopamine lies in the gut. And this is actually now the subject of studies trying to link what's happening in the gut with what's happening in our head. There are many conditions that are caused by problems with this brain in your gut. These conditions are surprisingly common. Let me give you some examples. Irritable bowel syndrome, for instance, or IBS. Other examples include common conditions such as gastroesophageal reflux disease, acid reflux, or heartburn. Some general symptoms for disorders of the enteric nervous system or this gut brain include nausea, unexplained abdominal pain, change in bowel habits. As far as risk factors for these disorders are concerned, we don't know a lot. The enteric nervous system in women appears to be more vulnerable to these changes than that of males. Part of it is maybe related to hormonal changes, but part of it may also be related to how the nervous system develops in females. A third component is perhaps social in nature. Women may be more likely to seek health care than male counterparts for these disorders. The treatment for these conditions is difficult. It's an area that has not received a lot of attention, both by scientists, physicians, and then of course by the lay public. In our laboratory, we are studying all aspects of this enteric nervous system. We are also looking at using the brain in the gut as a surrogate for changes in the big brain. We're taking biopsies from the gut and examining the nerves in those biopsies in patients with Parkinson's and trying to see if we can identify changes in the neurons in the gut that would indicate similar changes in the brain. And finally, and very, very exciting aspect of our research is that we are able to identify neural stem cells from gut biopsies. And these neural stem cells theoretically have the capability of developing into all kinds of neurons, not just those within the gut, but potentially in the big brain. So they may serve as a very convenient and readily accessible source of neural stem cells from the patient's own body.
My name is Rosalind Womack and I live in East Palo Alto, California. I applied for the National Rebuilding Together Day program. All these people coming out to help and volunteer, it's overwhelming because I remember when I used to volunteer for people and now I'm on the other end and it's just, I can't believe it. I don't have words to express what I feel.
Today we have National Rebuilding Day, which is across the country. And so we've got about 40 volunteers today who are doing a variety of things, painting, landscaping, replacing windows that have been broken, etc. All three teams that are here today are from Stanford. We have a nice collaboration between the directors group at Stanford Hospital and Clinics, and we have Stanford University Housing and Dining. And we also have a nice team of individuals from the Catholic community at Stanford.
We're joint venturing this year with Stanford Hospital on a project here for Rosalind Womack in renovating her house. So far it's been a really positive effort with the hospital this year. It's just an awesome day altogether, and it's wonderful to be here.
What we've been doing here today is landscaping the backyard, and here we have some flowers that we're going to be putting in the backyard. Rose, the homeowner, she really likes daisies, so we're going to go ahead and give her some daisies that she can enjoy. I got involved because I think Stanford Hospital and Clinics is a vital part of the community, and I enjoy doing stuff like this.
I just want to say thank you to Stanford Hospital, to Stanford University, to all the volunteers, all the people that have helped me. It's a blessing, and there's no way that words could ever begin to express my gratitude and my heartfelt thanks for everything that's been done. I'm so grateful. Hi. Oh my God. Oh my God. Oh God. Oh my God. It's beautiful.